There are many controversies in medicine. Think of aspirin for primary prevention of myocardial infarction, or the age at which mammography might be introduced. Aspirin for venous thrombosis prevention is a very old controversy. And one might take the position we should leave this alone. It's done, let it collect dust on the back shelves. Now, it should be very clear that my intent is not to try to convince you that everybody should switch to aspirin for venous thrombosis prevention. But I believe it's very important that we set the record straight. Why is this important? Well, many of us are thrombosis physicians, cardiologists, internists, and we spend a lot of time working in thrombosis, and we'd like to prevent thrombosis. A lot of that thrombosis actually happens in the surgical wards, in the orthopedic patients, in the general surgical patients. And for many years, there's been a fundamental disagreement between surgeons and thrombosis physicians. Now, sometimes disagreements are good because they hone our critical thinking, and at the end of the day, it's best for patients. But on this occasion, the divisions are so deep that orthopedic surgeons have developed separate guidelines, quite separate from the American College of Chest Physician guidelines on thrombosis. The two are going in opposite directions. One of the reasons is that there is a fundamental distrust by surgeons of thrombosis physicians. And the surgeons say, you thrombosis physicians are selective in your interpretation of the literature to support your own beliefs. Look at the example of aspirin. We know it works. You're just putting your head in the sand. And on this point, I believe the literature supports their case. So I would like to start with a historical perspective on the role of aspirin for the prevention of venous thrombosis. And already 40 or 50 years ago, there was much discussion in the literature, indeed well over 100 years ago, Virchow, in the days of Virchow, but more recently, there was a recognition from experimental evidence that arterial clots are white clots, thus they're comprised primarily of platelets, and venous clots are red clots. They're composed of fibrin clots. And it is known that aspirin works primarily by blocking platelets, and anticoagulants such as enoxaparin or the new drugs, rivaroxaban, primarily target fibrin or the formation of fibrin or inhibit the formation of fibrin. And thus, for a long time, experts have said aspirin's effective for arterial thrombosis because it blocks off white clots. Aspirin is not effective for venous thrombosis. And they point to many small trials conducted in the 70s and 80s, which were inconclusive, trials of aspirin for venous thrombosis prevention, which were apparently inconclusive or had conflicting results. In 1994, the Anti-Thrombotic Trialist Collaboration, which is led out of the UK, did a meta-analysis, a pooled analysis of all of the trials of aspirin for venous thrombosis prevention. And a summary of these more than 50 trials is presented on this slide. Now, not all these trials were aspirin, some of these were non-aspirin trials. Here are the categories of patients in this meta-analysis. Here are the numbers of patients, altogether 9,000 patients. And for those of you who are not familiar with these sort of graphs, on this axis here we have estimates of treatment effect, and here we have the estimates for the different categories of trials. And the important issue to note is that here is an odds ratio of 1. If the estimate is here, there is no treatment effect of antiplatelet therapy such as aspirin, compared with no antiplatelet therapy. For all these categories of trials, the estimates are to the left of 1, indicating a reduction in venous thromboembolism. Thus, in general surgery, in trauma, in elective orthopedic surgery, in any surgery in high-risk medical patients, all of the estimates are very consistent. What was the consequence of this meta-analysis? The bottom line is that thrombosis physicians rejected the results. They're small trials, many are open label, they're not methodologically rigorous. We used tests to detect venous thrombosis that we wouldn't use in this day and age. All sorts of different antiplatelet drugs were used. We can't rely on this information. And thus, the results were rejected. But not everybody rejected these results. Orthopedic surgeons in many places were delighted to see these results, and indeed, many embraced the results. And the reason is, if we could use aspirin for venous thrombosis prevention, it's so simple. It's 1 pill a day. It causes very few side effects. Sure, it does cause bleeding, but not as much bleeding, at least it was perceived, as the anticoagulants. And we don't have to monitor warfarin for those who would normally use warfarin, and thus very attractive for the surgeons. And there we have the major controversy, embraced by orthopedic surgeons, dismissed by non-surgeons. So in the wake of these data, and in the wake of this controversy, again, investigators combined between Oxford and New Zealand in particular, and Australia, designed a major trial called the PEP Trial, the Pulmonary Embolism Prevention Trial, to determine for once and for all whether aspirin works to prevent venous thrombosis. Now, the PEP trial is the largest ever study performed for venous thrombosis prevention. 17,000 patients. It ended up being performed in 5 countries. The New Zealanders said we want to include elective hips as well as hip fracture. So just in New Zealand, there were 4,000 elective patients, so most of them were hip fracture patients. A very simple trial. Patients coming into the trial who were having major orthopedic surgery would be randomly allocated to receive aspirin or no aspirin. The treatment would start on the day of surgery and would be carried on for 35 days. Patients would receive any other treatment that was standard therapy. So if the patient needed a TED stocking, according to the surgeon, they'd get a compression stocking. If they needed an anticoagulant, they would receive an anticoagulant. And somewhere in the order of, I'm told, 42% of patients received an anticoagulant in this trial. This is very much like the trials that Dr. Bart, who's sitting at the front here and is your next speaker, does every day of his life. Large trials where we randomize patients to treatment A or treatment B on top of routine therapy. In fact, the cardiologists are so familiar with this, they would never question a trial of this design. The outcome was only those events that matter to patients. No venograms, no ultrasounds. And don't get me wrong, I'm not saying it's bad to do those tests, but this was a very simple, pragmatic study, and only the things that mattered to patients would be counted. And here we have all the co-therapies that were used in this trial. The results of the PEP trial in this hip fracture group were overwhelmingly positive for aspirin. Here we have the 3 types of outcomes: deep vein thrombosis, non-fatal pulmonary embolism, and fatal pulmonary embolism. And the white is the deep vein thrombosis, here is the non-fatal PE, and here is the fatal PE. All 3 categories of outcomes were very clearly reduced. 2.5%, 1.6%, about a 1/3 risk reduction. Now, not everything was positive in this trial. Here is a very interesting result for myocardial infarction. We would have expected aspirin to reduce myocardial infarction, and in fact this question as to whether aspirin can prevent myocardial infarction is presently being tested in a trial being run out of our place in Hamilton by Dr. Devereaux of 10,000 patients looking at perioperative aspirin to prevent MI. And incidentally, we're also going to record venous thrombosis. Now, what are the strengths of the PEP trial? I believe it's the optimally designed trial. In fact, I think it's the type of trial that we should be trying to do for venous thrombosis prevention. It's the best design if it's feasible. It's the largest ever trial. Randomization was concealed. Investigators were blinded. All outcomes were important for patients and objectively confirmed. Patients were followed up. More than 99.6% of patients received follow-up. Because of the large trial, we get very precise estimates of treatment effect. And because the trial had such wide entry criteria, the results are widely generalizable. Basically, anybody who you do surgery on for hip fracture the results of this trial would apply to that patient. Now, no trial is perfect, and PEP has some weaknesses. But I'd put to you that most of the criticisms of PEP trial are unfounded. The one typical example is, well, patients in PEP received anticoagulants, 40% of them. If that was a reason to invalidate a trial, that would be saying the trials of aspirin in myocardial infarction are not valid because some people also got Plavix. Well, in fact, it wasn't quite designed that way, but it would be saying a trial of an antihypertensive therapy in patients with cardiovascular disease is invalid because some patients were already getting antihypertensive therapy. One of the other criticisms was that there were changes in study design prior to unblinding. This is routine practice. I don't think I've ever been involved in a trial at McMaster where sometime before the final study is closed, that a change in design is made based on progress during the study. As long as it's unbiased and not driven by the results of the trial, that's a perfectly legitimate approach. So if we were to summarize the results of the antiplatelet trialist collaboration 1994 data and the PEP hip fracture patients, it would look a little bit like this. And here are the relative risks: a 29 to 30% reduction in DVT, a 26 to 64% reduction in PE, a 58 to 70% reduction in fatal PE, no reduction in mortality, and a 24 to 75% increase in bleeding. And here are the absolute numbers, again, very consistent estimates between the antiplatelet trialist collaboration and the PEP trial. Furthermore, when we pull the data from the PEP trial and the antiplatelet trialist collaboration, here are the numbers. High-risk medical patients is unchanged because there were no PEP patients who were high-risk medical. There were no PEP patients in general surgery. But here we have the elective orthopedics and the hip fracture patients. All of the estimates well and truly to the left of unity, tight confidence intervals, highly significant p-value. The probability of this result occurring by chance alone, given the null hypothesis of no difference, is less than 1 in, 100,000 or 10, I can't even determine the numbers from here, but a very low probability that this is due to chance. The same numbers for pulmonary embolism. I won't go through all the numbers again, but very convincing evidence that antiplatelet therapy compared with no antiplatelet therapy reduces venous thromboembolism. So I think there is conclusive evidence that aspirin works to prevent VTE. What we don't know, and what many of us suspect, I think, is that anticoagulants are more effective than aspirin. There have been 6 trials that I could identify that involved at least 200 patients that have compared an anticoagulant with aspirin for venous thrombosis prevention. Unfortunately, in most cases, they were woefully underpowered. The anticoagulant comparators, there's a whole range of them. The aspirin doses are from anywhere from 100 to 650 milligrams a day. And here are the estimates for DVT, which overall seem to suggest there is a significant reduction in DVT. 4 of the trials didn't report PE. 1 suggested a 15% reduction, and 1 a 200% increase with anticoagulants compared with aspirin. What's also interesting is that aspirin and anticoagulants appear to be associated with fairly similar rates of major bleeding. So I'm not sure that we have a definitive answer whether anticoagulants are better than aspirin, or perhaps whether aspirin is a little more effective in pulmonary embolism and less effective in preventing the small clots that occur in calves. I do believe that a strong case can be made to perform a definitive trial comparing aspirin with anticoagulants. So to summarize these results, I think there is compelling evidence, both from meta-analysis data and supported by the PEP trial, that antiplatelet therapies in general, and aspirin in particular, reduces venous thromboembolism, in particular patient-important symptomatic DVT by about 1/3, and patient-important pulmonary embolism by about 1/2 in surgical and medical patients. If it's taken around and after surgery, with uncertain effects on myocardial infarction and no reduction in all-cause mortality. The effects of antiplatelet therapy on venous disease are consistent with the effects of antiplatelet therapy in atrial fibrillation, where aspirin has a modest effect and the combination of aspirin and Plavix has a greater effect. And in the left atrium, the characteristics of thrombus formation there are very similar to those in the venous system. With respect to the key question of whether antiplatelets are as effective as or less effective than anticoagulants, the data are very limited. Overall, I think it's fair to say that anticoagulants would seem to be somewhat more effective than aspirin for DVT prevention, but the jury is still out here, and I do hope that at some stage we will get a major trial, and there are major efforts ongoing in the United States, led by orthopedic surgeons, to initiate such a study. Thank you very much for your attention.